Good day everyone, I'm Dr. Ting from Hospital Taiping, and for this session, I would like to talk about spine and spinal cord trauma. Hopefully by the end of this session, you will be able to suspect or recognize spinal injuries among trauma patients during primary and secondary survey, able to appreciate the importance of spinal motion restriction, when and how to perform it. Thirdly, diagnosis and investigation that carry out in trauma patients with suspected spinal and spinal cord injury. And lastly, understand the need of referral and further management at tertiary center. Spine injury, with or without neurological deficit, must always be considered in polytrauma patients. This is because up to 10% of them have associated spinal injury, and up to 5% of traumatic brain injury patients have associated cervical injury. Cervical spine is the most commonly injured region, and up to 10% of patients with cervical fracture have a second non-contiguous vertebral column fracture, either in cervical, thoracic, or lumbar region. Therefore, detailed assessment and evaluation for spinal injury is very important in polytrauma patients. As we all know, during resuscitation of an unstable trauma patient, airway, breathing, and circulation is always our first priority before assessment of spine and neurological function come into picture. However, please don't forget that there's always a plus that comes along with our airway, which is the cervical spine control. This is because cervical spine is the most mobile and exposed region among all the vertebrae, making it more susceptible to potential injury. For patients with potential spine injuries, excessive manipulation may cause additional neurological damage and worsen patient's outcome. If there's precaution to protect the spine, evaluation of spine and exclusion of spinal injury can be safely deferred while we secure the airway, breathing, and circulation in unstable trauma patients. Spinal protection measures include the following. Firstly, cervical collar application. Second, maintain patient in supine position on a firm surface. And thirdly, using spinal board during patient transportation. Apart from that, manual inline immobilization should be carried out during airway management, for example intubation, to maintain a neutral position of the neck and prevent hyperextension. Although the dangers of excessive spinal motion have been well documented, but we need to remember that prolonged usage of spinal board and cervical collar is associated with some possible complications. Pain and discomfort over the neck and mandible is the commonest side effect of cervical collar, especially in conscious patients. Apart from that, patients may develop pressure injuries over the bony prominence after prolonged usage of spinal board. Therefore, we should try to minimize the time patients spend on that and remove it as soon as possible during initial assessment. Due to straps application across patient's chest wall while on the spinal board, there's potential reduction in respiratory function and results in respiratory compromise after prolonged usage. Although this is not common, but extra care is needed, especially for patients with pre-existing pulmonary condition, and remove it as early as possible during initial assessment. As mentioned earlier on, spinal board should be used only during patient's transportation, for example, extraction of patient from the site of incident, and every effort should be made to remove them from spinal board as soon as possible. In order to have a better understanding regarding clinical presentation of spine and spinal cord injury, I will refresh your memory regarding basic yet important anatomy and physiology. Our spinal column consists of 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar vertebrae, followed by sacrum and coccyx. Cervical spine is the most vulnerable region because it is relatively mobile and exposed. Up to 55% of spinal injury occur over here. Cervical canal is wide over C1 and C2, so it is not common to associate with spinal cord injury compared to other regions. Most patients with injury over C1 and C2 are neurologically intact upon arrival to hospital. However, for patients with upper cervical injury, especially C3 and above, there's risk of phrenic nerve paralysis and subsequently results in respiratory depression and apneic episodes. 1/3 of trauma patients with upper cervical injury pass away at the scene due to apnea. For C3 and below, spinal canal is much smaller. Therefore, vertebral injury over this region are more likely to cause spinal cord injury. As we mentioned earlier on, About 55% of spine injury occur over the mobile and exposed cervical region. In compared to C-spine, thoracic spine mobility is much more restricted. Together with the additional support from ribs cage, incidence for thoracic injury is much lower. Thoracolumbar junction, which is from T11 to L1, is a fulcrum between the immobile thoracic vertebra and the more flexible lumbar vertebra, makes it more vulnerable to injury, and 15% of spine injuries occur over here. Spinal cord is a tubular structure consisting of neuron and axons. It begins at the caudal end of medulla oblongata and commonly ends at L1 as conus medullaris. It travels within the spinal canal, protected by vertebral column and surrounded by 3 layers of spinal meninges. Those spinal nerves that arise from the distal end of spinal cord are bundled together and forming cauda equina. Main function of spinal cord is transmission of sensory and motor signals between peripheral nervous system and cortex, as well as reflex coordination. Among the many tracts in the spinal cord, there are 3 that can be assessed clinically, namely corticospinal tract, spinothalamic tract, and dorsal column. All of these tracts are paired, so they can be injured either on one side or both sides of the cord. First, let's talk about the corticospinal tract. It is located over the anterior and lateral segments of the cord, as you can see in the photo. Both anterior and lateral corticospinal tract control motor function on the same side of the body. Main function of lateral tract is to control movement over the upper limb and lower limb, whereas anterior tract involved in the neck and trunk movement. For conscious and cooperative patients, we can assess corticospinal tract by voluntary muscle contractions. But for those who are not conscious and not cooperative, involuntary response to painful stimuli can be performed. Spinothalamic tract is located over the anterior and lateral aspect of the cord. Main function of this tract is to transmit pain and temperature from the opposite side of the body to sensory cortex. In trauma setting, we assess spinothalamic tract function by pinprick sensation. Dorsal column is located over the posterior medial aspect of spinal cord. Main function of this tract is to transmit proprioception and vibration sensation from the same side of the body to sensory cortex. For conscious patients, we assess the function of dorsal column by checking the position sense of toes and fingers or vibration sensation by using a tuning fork. Myotome is defined as group of muscles which is innervated by a single spinal nerve root. However, assessment for myotome is more complex compared to dermatome, as each segmental nerve root innervates more than one muscle, and at the same time, most muscles are innervated by more than one segmental nerve roots. In order to simplify this, specific muscle or muscle groups are identified to represent each single spinal nerve segment. This is also known as key myotome. The picture on your left showing the key myotomes that we use to evaluate the level of motor function, which includes C5 to T1 and L2 to S1. The key myotome should be tested on both sides with scoring from 0 to 5. However, if the motor function is not able to be assessed, for example, patient on immobilization splint for suspected fracture or dislocation, or on paralytic agent after intubation, it should be documented as not testable. Dermatome is the area of skin innervated in the sensory axons of a single segmental nerve root. The picture on your left showing dermatome distribution that extract from Asia chart, and key dermatome is listed in the table. In trauma setting, pinprick sensation and light touch is tested in each dermatome for both left and right side based on a 3-point scale. Score 0 indicates absence of sensation, whereas score 1 indicates altered sensory, which can be reduced or hypersensitivity. Score 2 indicates normal sensation. If sensory examination is unable to perform, for example in unconscious patient, it should be documented as not testable. Some of us may mistakenly thought that neurogenic shock is similar to spinal shock, but the truth is both of these are two completely different clinical conditions. Neurogenic shock is a form of distributive shock whereby it is associated with injury over the cervical or upper thoracic, usually T6 and above. Cervical or upper thoracic injury may result in disruption of the descending sympathetic tracts. Loss of sympathetic tone together with unopposed parasympathetic response result in peripheral vasodilation, pooling of blood, and the end result is hypotension. Apart from that, loss of sympathetic innervation to the heart can result in bradycardia, which is a distinctive feature of neurogenic shock. In another situation, if there is concurrent hypovolemic and neurogenic shock, heart rate is no longer a good indicator in detecting hypovolemia, as patient is unable to mount a tachycardic response to volume loss. However, in any trauma patient with hypotension, it is always a must to rule out other causes of shock, especially hypovolemia and obstructive shock as the potential cause. This is because hypovolemic shock is the commonest type of shock in trauma patients and can be present concurrently in addition to neurogenic shock. Regarding obstructive shock, common examples include tension pneumothorax and cardiac tamponade. Without a proper assessment and in-time intervention, patients with obstructive shock may deteriorate fast and eventually arrested. The physiologic effect of neurogenic shock, which includes hypotension and bradycardia, are not reversed with fluid resuscitation alone. Furthermore, over-resuscitation with fluid and blood products in neurogenic shock can result in fluid overload and pulmonary edema. After a moderate volume replacement, vasopressor is usually indicated to maintain tissue and organ perfusion. Noradrenaline is a good first-line agent for neurogenic shock as it has both alpha and beta activity, hence can help to improve peripheral vasodilation and bradycardia. Apart from vasopressor, atropine may be used to oppose vagal tone and counteract hemodynamically significant bradycardia. As opposed to neurogenic shock, spinal shock is a clinical state that refers to loss of muscle tone and reflexes, together with loss of motor and sensory function below the level of injury. Other signs of spinal shocks include urinary retention, loss of bulbar cavernosus reflex, loss of cremasteric reflex, and priapism. This is not a true shock and usually transient, which lasted from days to weeks. However, if the injury is occur over the cervical or high thoracic region, both spinal shock and neurogenic shock may coexist. Spine injury can have effects on other organ systems as well. For patients with spinal cord injury and couldn't perceive pain, there is potential that a serious injury elsewhere in the body is masked. For example, patients who sustained intra-abdominal injury but didn't complain abdominal pain because he or she couldn't feel the pain. When there's a spine injury, one of the important assessments is breathing effort with potential respiratory failure. This is especially with patients with cervical and upper thoracic injury. Hypoventilation or apneic episodes may result from diaphragm paralysis, which is associated with C3 to C5 injury, or paralysis of the intercostal muscles, which is associated with injury to the lower cervical and upper thoracic. Therefore, close monitoring with serial examination is important in assessing and managing polytrauma patients with suspected spine injury. Spinal cord injury can further classify into complete and incomplete injury, as well as manifest as paraplegia or tetraplegia. Complete spinal cord injury is defined as absence of sensory and motor function below the affected level, whereas for incomplete spinal cord injury, it occurs when there's preservation of any sensory or motor function below the injured level, and this includes sacral sparing. Common examples for incomplete spinal cord injury includes anterior cord syndrome, central cord syndrome, cauda equina syndrome, and so on. Paraplegia refers to loss of motor and sensory function in the thoracic, lumbar, or sacral segments without involving the cervical region. Therefore, in paraplegia, upper limb function is preserved, but lower limb, trunk, and pelvic organ is affected depends on the level of injury. Tetraplegia refers to loss of motor and sensory function in the cervical region. This will result in loss of function in the upper limb, trunk, lower limb, and pelvic region. Signs of incomplete spinal cord injury includes presence of any sensation, voluntary movement in the lower extremities including toe flexion, voluntary external anal sphincter contraction, and lastly, sacral sparing, which means sensory preservation over the S4-S5 dermatome. Central cord syndrome is one of the examples of incomplete spinal cord injury that commonly occur. This is typically occur after hyperextension injury, for example, fall forward with face up, results in compression and contusion over the spinal cord. This can occur with or without cervical spine fracture or dislocation. Signs and symptoms of central cord syndrome includes disproportionate loss of motor function over the upper limb compared to lower limb, with varying degree of sensory loss. Prognosis for recovery in central cord syndrome is generally good. Anterior cord syndrome is another example of incomplete spinal cord injury. Anterior two-thirds of the spinal cord is affected either by trauma, commonly by forward flexion, or cord ischemia, results in loss of function in both cortical spinal tract and spinal thalamic tract. The end result is bilateral loss of power and sensory with preservation of vibration and proprioception. If cervical segment is involved, patient will be presented as tetraplegia, and if cervical segment is not involved, patient will be presented as paraplegia. Among the types of incomplete spinal cord injury, anterior cord syndrome carries the worst prognosis. Documentation regarding motor and sensory function in spinal cord injury patient is very important, not only to detect the level of injury, but also for further classification whether this is a complete or incomplete injury. ASIA chart produced by American Spine Injury Association is a very convenient and standardized way of documenting neurological finding. As you can see from this chart, key myotome and dermatome is clearly stated, together with the grading for motor and sensory component too. Canadian C-spine rule is one of the screening decision tools that we use in emergency department to further determine whether radiography is needed to safely rule out cervical spine injury among trauma patients. It is applicable for alert and stable adults who are 16 and above, whereby traumatic cervical injury may be a concern. However, it is not applicable for the following patients: trauma patient with GCS less than 15, hemodynamically unstable, age less than 16, presented with acute paralysis, those with pre-existing vertebral disease or previous cervical spine surgery. Let us go through this step by step. First, detecting any high-risk factor for cervical spine injury. This includes age more than 65, dangerous mechanism, or presence of paraesthesia in the extremities. If any of these high-risk factors is present, radiography is warranted to rule out cervical injury. However, if there is no high-risk factor, we will move to next step, which is looking for a low-risk factor that allows us to safely assess patient's neck movement. Low-risk factors include any of the following. 1. Simple rear end motor vehicle collision. 2. Patient was in sitting position in emergency department. 3. Patient was able to walk at any time after trauma. 4. Delayed onset of neck pain. And lastly, absence of midline cervical tenderness during examination. If any of these low-risk factors is present, we can proceed to the third step, which is actively rotate patient's neck. However, if none of these is present, radiography is warranted. For patients without any high-risk factors and presence of any low-risk factors, we can subsequently request them to actively rotate their neck 45 degrees to the left and right. If they can't perform the active rotation or complaining of pain, then radiography is warranted. However, if they can perform active rotation without pain, we can rule out cervical spine injury without radiograph. Sensitivity and specificity for Canadian C-spine rule is slightly superior compared to Nexus criteria. Hence, application of this rule can help in reduce the rates of unnecessary X-rays. However, these rules can be quite difficult to memorize in view of presence of multiple criteria. Therefore, using a smartphone app, for example, MD calculator, is recommended while applying this rule. Nexus criteria is another clinical decision tools that help us rule out cervical spine injury among stable trauma patients without the use of imaging. According to this rule, for a stable trauma patient that fulfills all 5 criteria, we can safely rule out cervical spine injury. However, If any of these rules is not fulfilled, radiography is warranted. The 5 listed nexus criteria includes: firstly, no posterior midline C-spine tenderness; second, no evidence of intoxication; third, normal level of alertness; fourth, no focal neurological deficit either by patient's complaint or clinical examination; and lastly, no painful distracting injury. In comparison to Canadian C-spine rules, nexus criteria is relatively simpler to apply, but Canadian C-spine rules perform better in terms of sensitivity. Regarding the management of spine injury, the key principle during primary survey is to apply spinal precaution measures in all high-risk patients. This includes those who are semi-conscious or unconscious, patients who sustain injury above the clavicle, polytrauma patients, and those with obvious neck deformity. However, we shouldn't attempt to reduce or correct any neck deformity. Such patients should be left in the position that they are most comfortable with. Spinal motion restriction should continue until the assessment of spinal injury is completed and being ruled out either by clinical or imaging. During airway assessment, gentle chin lift is recommended over head tilt, as head tilt may cause hyperextension over cervical spine. For high-risk patients, rigid cervical collar and head immobilizer should apply. Rigid collar will limit flexion movement, whereas head immobilizer will limit the lateral rotation of cervical spine. Maintaining patient on supine position on firm surface or spinal board will prevent extension of C-spine. For breathing assessment, it is important to observe breathing pattern, as hyperventilation and apnea can be complications of cervical and upper thoracic injury. In such patients, intubation and mechanical ventilation is usually indicated. As you can see in this photo, main function of rigid cervical collar is to limit flexion of C-spine. The side head immobilizer is applied to limit rotation of C-spine. Firm surface underneath is to prevent extension. For circulation, we must always rule out hypovolemic shock in a hypotensive trauma patient, as hypovolemia is the commonest type of shock in trauma. Management of neurogenic shock includes adequate amount of fluid resuscitation followed by vasopressor administration. For disability, neurological function includes motor, sensory, and reflexes. However, this can be challenging in patients who are semi-conscious and unconscious. For those patients, serious assessment is needed, especially when their conscious level is regained. Up until then, such patient is needed to continue with spinal motion restriction. For secondary survey, it is important to expose patients back and assess for injury over the spine. This includes ecchymosis, hematoma, step deformity, and open wound. Again, spinal motion restriction is needed during secondary survey. Therefore, lock roll maneuver is performed while turning patient over for examination. Regarding investigation for spine and spinal cord injury, X-ray and CT scan is commonly ordered in emergency department, depends on the available modalities. X-ray views that needed include AP and lateral for respective spine, with extra open mouth view for cervical spine. However, limitation of X-rays includes difficult to demonstrate non-displaced injury. In such cases, a more sensitive CT scan is usually helpful. Apart from that, when the lower cervical spine is not adequately visualized on X-ray, commonly C7-T1 junction, CT scan should be considered, especially in high-risk patients. MRI spine is a good modality in evaluate soft tissue of spine. This includes spinal cord, intervertebral disc, and ligaments. MRI usually ordered by orthopedic surgeon after the initial stabilization if clinically indicated. In summary, spine and spinal cord injury is not uncommon, especially among polytrauma patients. Therefore, we should always make sure effective spine motion restriction during primary and secondary survey to prevent additional neurological damage that may worsen patients' outcome. Recognize the high-risk patient, adequately restrict spinal motion followed by thorough neurological examination is the key while managing a patient with spine and spinal cord injury. With that, thank you.